Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, When Heartburn is Acid Reflux, presented by Dr. Zaid Imam, gastroenterologist with Washington Township Medical Foundation. Dr. Imam's philosophy of care is to tailor patient care to the patient's individual needs. He goes out of his way to listen to their concerns, address their issues, and achieve a level of healing that allows them to go back to their normal lives and enjoy life. With this approach, Dr. Imam has continuously committed himself to deeply understanding his patients' preferences as well as studying their history to gauge potential outcomes. Please welcome Dr. Imam.
Good afternoon, everybody. My name is Zaid Imam, and I'm a gastroenterologist at Washington, and I'll be talking to you guys today about understanding reflux disease and what is reflux disease, and how are those different, and how can we better help you guys with these problems and complaints that you might have. So reflux is a very common problem, and as a matter of fact, reflux disease is so common that 1 in 5 adults in the United States do suffer from gastroesophageal reflux disease, or GERD for short. Millions of people are on proton pump inhibitors, one of the most common medications prescribed for acid reflux, better known by names like omeprazole, lansoprazole, Prevacid, Prilosec, you name it. However, 40% of these patients will still have clinical symptoms. This could be because we're not treating the right problem, which is they could be reflux but not GERD, or it could be that people are not taking the medication the way they should, not the right dosage, as well as other factors and features that are patient-related that may be influencing their response. Some of these patients with reflux, some of people who have gastroesophageal reflux disease, may develop precancerous conditions of the esophagus or the food pipe, known as Barrett's esophagus. And that's about 10 to 15% of these people. And those patients are at higher risk of developing esophageal cancer, and are a select population which I would see and follow up for screening procedures to look for early changes that could be cancerous and triage them accordingly. So what is gastroesophageal reflux disease? Reflux, in layman terms, or as we think of it, is a feeling of something coming up in the food pipe or the esophagus. Reflux disease, or it becomes a significant problem when these issues of reflux become symptomatic, meaning they cause you troubles or difficulties and interfere with your day. And reflux disease is also identified by visualizing inflammation or looking at inflammation when we do endoscopic procedures or camera testing to look at the esophagus or the food pipe. Now, normally, as we can see here, this is a diagram highlighting the stomach and the food pipe. The diaphragm is a large sheet of muscle which acts as a sphincter or as a valve, preventing food and materials from going from the stomach as food is digesting up into the esophagus. Now, the diaphragm or the sheet of muscle does relax at times as you're breathing, as well as this valve kind of lets some of air out, and some people will burp, or it will just, like, without feeling it, come out so you don't ingest or swallow too much air. And when that happens in some people, a small amount of the acid in the stomach can go up in the esophagus. Part of this is physiologic and natural. However, in some people, because of increased esophageal sensitivity and increased amounts of reflux coming up, the nature of the secretions of the stomach itself, or changes in the barrier lining that kind of protects the esophagus itself because of different conditions, including anatomical conditions where the stomach slips above the diaphragm, as well as other conditions, can predispose you to acid reflux. So while this part of this is physiological, some people tend to experience more symptoms from these physiological changes, and in some people there are problems which predispose to an increased amount of reflux. If the stomach does not empty well and things sit in the stomach for longer, this can also promote reflux and acid coming up into the esophagus. As you can imagine, more relaxation to let air out, and as this happens, more food and drink, digested food and drink will actually come up and irritate the esophagus. So what are the symptoms I should be looking for? Those symptoms, first of all, is heartburn. Heartburn is a feeling of burning behind in the middle of the chest. Regurgitation is a feeling of food or drink coming back up. Chest pain is a feeling of tightness or discomfort or pain in your chest. Those first three symptoms are the most common symptoms of gastroesophageal reflux disease. However, there are other structures in your chest other than your food pipe, including your heart and lungs. And so it becomes very vital and important that whenever you have any of these complaints, to address them with your physician. And the more details they learn about these complaints, we're able to kind of piece the stories together to be able to guide us whether we think your pain is relating to one or more of these organs. And it's not unusual that a physician, your primary care physician or your gastroenterologist would recommend a part of a cardiac or a lung workup for your chest pain before just attributing it to acid reflux disease. However, in some cases, it's quite straightforward and apparent to us that this is the problem, and we will proceed with treating the gastroesophageal reflux and seeing how you respond. On rarer occasions, complaints like hoarseness and cough can also happen. However, these are less likely and less common, and often are caused by other problems, like problems of the throat or the lungs, and need to be addressed first before entertaining reflux as a possibility. So when should I talk to my doctor if I have any of these symptoms? If any of these symptoms are new to you and you've never talked to your doctor about it, then you should definitely bring it up. Bring it up first to your primary care physician, and if they feel the need to, they will refer you to a gastroenterologist. If you are not tied in with a primary care physician and you feel your symptoms are quite severe, or your symptoms have been existent for a long time but now are worsening, that'd be another time to check in with a doctor, whether it be your primary care or a gastroenterologist. Difficulty swallowing, meaning if you feel that food or drink gets stuck as you swallow or eat or drink on a regular basis, that would be a sign that you should always follow up and talk to a physician about. If you're losing weight and you do not understand why, or it's unexplained, that's another important feature as well as having these symptoms. Bloody stools or blood in the stools, black tarry stools, and vomiting, whether vomiting with blood or without blood, are other features that you should definitely mention to your doctor, because these suggest problems for which we often need to do camera testing or endoscopy to further evaluate the issue at hand. Does everybody who have heartburn have reflux disease? And the answer is not necessarily, because like we talked about when we went back to the diagram, there are mechanisms by which people can feel the feeling of heartburn without having acidic material go up, and that could be related to the fact that their esophagus might be more sensitive, a condition known as functional heartburn. Other people will have food and drink not even make it to the stomach, and because of motility problems, muscular problems of the esophagus, the food or liquid doesn't make it to the stomach, but retains in the food pipe or the esophagus. And when it sits there, it irritates the lining because it's not a reservoir. It's not created or meant to be that way. And so this can make people experience heartburn too. So not every person with heartburn has reflux disease. However, reflux disease is the most common cause of heartburn, and often treatment for reflux disease will be suggested when you are complaining of heartburn. So how do I approach a patient with reflux? When you walk into my office and start talking to me, the first thing I do is listen to your story, identify and explore your symptoms, things that could be relating to them. Here comes your role in keeping details about your symptoms and trying to keep track of what seems to be related or unrelated to your symptoms. Big things are certain foods or food triggers, certain times of the day which the symptoms seem to be worse, certain things that seem to make the symptoms worse or better, certain over-the-counter medications that you could have used, And those are all questions that I'll be asking you even if you don't mention them. But if you do mention them, those are very helpful details into guiding me one way or the other. Then I will ask you the lists of symptoms that I talked about, including bleeding, vomiting, difficulty swallowing, pain with swallowing, and those are known as red flag symptoms. I will also be looking at your blood work and making sure that things look okay and you're not anemic or have any low blood counts that are otherwise unexplained. And then after that, we'll make a plan together on whether further testing is needed versus a trial of treatment. Here I want to highlight how important it is that a trial of treatment is often a test in itself. Because if you do respond to a certain treatment for a condition, you're likely to have had that condition, and so that is a test in itself to identify or diagnose the condition. With a problem such as acid reflux being as common as it is, doing cumbersome advanced testing to establish whether every person truly has fits the parameters of acid reflux is not feasible in reality or in practice. And so often we need to use the treatment rather than have you go through additional testing. So I would not be surprised if that is the case of your encounter or your experience when you visit your gastroenterologist or primary care physician. What are the possible treatments? To all of my patients with reflux-type symptoms and reflux disease, I would suggest simple lifestyle changes, including head-of-the-bed elevation. And here I'd like to highlight that rather than propping yourself up on pillows, which is not as helpful because you tend to shift position during the night, elevating the wedge of the bed itself by installing a wedge under the head of the bed is actually more helpful because it maintains the whole bed in an elevated position, which you are more likely to keep or stay in that position while you're sleeping. Avoiding late night eating is a really big one. So make sure you do not eat any solid food at least 1 or 2 hours, or I would say more on the side of 2 to 3 hours as a matter of fact before going to bed. Especially if you have diabetes, as a lot of patients with diabetes do have delayed and slow digestion, and sometimes late night eating can just, like we said, the food sits in the stomach, the food needs to digest, part of the acid from the digestion of the food comes up your esophagus, and that irritates your esophagus lining, makes you symptomatic. It's interesting that a lot of people with early morning symptoms are actually a reflection of having bad nocturnal or night habits the day before, because they eat, they sleep, they have all the acid reflux all throughout the night. They might not feel it while they're sleeping, but in the morning they wake up and they feel sore in their chest, they feel some discomfort, they feel the heartburn, it hurts, it bothers them. And so that's quite common actually. Avoid peppermint, because the peppermint relaxes the valve and actually promotes things going up. Peppermint is, a well-known herbal remedy for a lot of stomach aches and pains, can be used in irritable bowel syndrome, but is not your biggest friend in cases of reflux. Minimizing caffeine, going half-caff, decaf can sometimes help for some people. But really, in terms of food triggers, what foods should you avoid is really guided by yourself. Avoiding larger meals, late night eating, and the specific foods I've mentioned are really the biggest things. Some people tend to avoid red sauces, things like that, fattier foods, and it works for them, but for other people it doesn't. And so really trying and experimenting with food on your own behalf might be the most helpful in terms, short of these recommendations, in terms of identifying what helps you the most from a lifestyle perspective. In terms of medications, there's different classes of acid reducers, some of which are over-the-counter, and some of which are prescription-based. And some of which the prescription-based medications are the same ones as over-the-counter, but they're used in different dosages. Surgery is always an option in acid reflux and reflux disease. However, it is reserved for selected patients. It is because surgical treatments for acid reflux do have their own set of complications, and they can cause their own set of problems. And so they are reserved for people with symptoms that are not responding to traditional medications and lifestyle changes, and for select groups of patients. If you think that you might be interested in surgery as an option, you should just bring that up to your physician and they would explain to you why they think you are or not a good candidate. Often before proceeding with surgery, you would require significant amounts of preoperative testing, including confirming the diagnosis using complex testing, which is a pH monitoring, which we're monitoring the exact how acidic the reflux that's coming up in your esophagus is, using special probes, monitoring the motility or the muscle movement of the esophagus, and those are not the easiest tests to go through, so they are entertained only when we think surgery is something we need to pursue, or we're not sure about our diagnosis because you're not responding to the treatment the way you should. What are common tests I will order for people who come with reflux complaints to me in the clinic? I will look at their blood work. A lot of people will have some blood work that's already ordered by their primary care physician, and reinventing the wheel is not helpful. So I don't tend to reorder something that's already been recently ordered. However, if no blood work has been recently ordered, it would be prudent to check at least your blood counts and make sure that you do not have any anemia or low blood counts. Additional tests I would order or perform are endoscopies, which are camera testing while you're asleep, and we take a camera the size of my finger down into your throat, the stomach, the small intestine, and the food pipe, taking pictures along the way, identifying any anatomical problems, meaning changes in your normal anatomy that could predispose you to reflux, and identifying any changes that are related with chronic reflux. We do perform that in any patients with any red flag symptoms that we have mentioned earlier, and patients who do not respond to traditional medical therapy. And it can be sometimes insightful, however, sometimes it's a test of exclusion, making sure there aren't these problems. And sometimes will not give us the diagnosis, but will give us what it is not. And then we could move on to more sophisticated testing like acid monitoring studies and manometries. And then again, I'd like to stress the fact that a trial of medication is sometimes a test in itself, and that might be something that would be suggested by your physician, treating physician, rather than ordering more testing, just going for a trial of a certain medication. And that kind of concludes my presentation for today. Thank you guys for listening, and I'm open the floor for any questions.
Great. Thank you, Dr. Imam. Very good presentation, good information, but we do also have some questions. Can you please tell us again, what are the red flag symptoms that we should be looking for?
So I'll go back to the, to kind of keep a visual point. So the red flag symptoms is somebody who is older in age, meaning 60s or older, somebody who has had existing symptoms that are getting worse, difficulty swallowing, meaning food or drink getting stuck, unexplained weight loss, your blood counts being low, blood in the stool, vomiting. So all those features are red flag symptoms. To make it easier, it's hard to remember all of these. I mean, those are the things that your doctor should remember, not yourself necessarily. If you have a concern, bring it up to your doctor. Don't brush it aside. Have them listen to you, and they will ask you about these questions. They will look at your blood work. They will look at your history. They will identify whether these things are present or not. And if you are a candidate for endoscopy or you need endoscopy, then you should be referred for that.
Okay, thank you. The next question we have is, what complications could occur if my condition doesn't improve?
So some complications from untreated reflux can be more acute, and other complications are more chronic. So more acute complications can, because of the swelling in the esophagus, some people can have difficulty swallowing, other than the fact that the symptoms do interfere with your life. On a short run, prolonged inflammation in the esophagus can predispose you to scarring in the esophagus, which can cause narrowings. And these narrowings can cause further difficulty swallowing, especially swallowing tougher foods, harder foods. Chronic inflammation can also predispose you to Barrett's esophagus. Barrett's esophagus is a precancerous condition of the esophagus, which increases your risk of esophageal cancer. An untreated reflux can be a risk factor for that. So those are the big things that we worry about if your reflux is untreated. Other than symptoms, other than inflammation that's untreated, that can cause bleeding, it can cause you to have worse symptoms, it can cause narrowings, it can cause Barrett's esophagus or a precancerous condition of the esophagus.
Okay, thank you. We have, our last question is a two-part question. I take over-the-counter antacids. How long should I take them before consulting my doctor? And are there long-term disadvantages of taking antacids?
So when we say antacids, we often refer to, when we say antacids from a medical perspective, we often refer to Tums, as to put it simply. However, often people refer to antacids as a bigger category of medications. So that includes Tums, but it also includes acid reducers in the family of H2 blockers like famotidine, also known as Pepcid, like omeprazole, also known as Prilosec, things like that. So there are some side effects that are unique to every group of medications, and they're quite extensive. So you need to go through, depending on which antacid and acid reducer you're taking, you'd want to bring that up to the attention of your physician, and they can walk you through some of these long-term side effects of using them. To keep it simple, short-term side effects of using any of these medications, meaning for a few months, are close to nothing. They're overall very safe, well tolerated. They can give some common side effects like diarrhea, discomfort. On rare occasions, people can get allergic reactions from some medications. However, overall, the side effect profile is very favorable. When I think about long-term use, I'm thinking about 5, 10, 15 years of using the same drug on a regular daily basis. I think if you have new symptoms that have not been addressed, then you should bring them up to your physician. I usually think of symptoms being more significant when they are occurring 3 or more times a week, because it means that more likely than not in a course of a week, you're having significant symptoms that are affecting you in some way or the other. And so a frequency of symptoms that frequent should definitely be brought up to your physician. If you have a heartburn once a year occurrence, then that may be something you just take an antacid for, and just see how you feel and see if it resolves. However, if it's something that's happening multiple times a week or a frequent occurrence every month, then it's something definitely that you should bring up to your physician.
Thank you, Dr. Imam. This does conclude our presentation, and thank you for providing this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.